My name is Galperin-Aizenberg. The topic of this lecture is chest radiograph in COVID-19 pandemic, its role, suggested standardized reporting, and review of cases with CT correlation. The outline of the lecture is as follows, covering these respective subjects. Since December 2019, when COVID-19 epidemic started in Wuhan, China, it has rapidly spread outside of China and became officially declared as a pandemic by World Health Organization in March 2020. Since then, multiple hotspots have rapidly developed in Europe, Asia, and United States. As the pandemic was unfolding, a radiology community was learning about imaging features of this disease, mostly on CT, as that was the primary imaging tool utilized in China. Sensitivity, specificity of CT findings were widely discussed compared to that of RT-PCR, the reference standard test for the diagnosis. China even temporarily used chest CT as a standard of COVID-19 diagnosis. With the arrival and rise of the pandemic in United States, with 500,000 cases confirmed to date, other imaging modalities have risen as potentially useful tools for COVID-19 pneumonia, particularly in the context of insufficient PCR testing. Chest radiograph was and is instrumental in Europe and United States. Ultrasound was used in Europe and Iran. On March 11th, the American College of Radiology issued a statement about use of chest CT for COVID-19. The statement had a few major points or broad recommendations. To summarize, not to use CT as a screening test, use it sparingly and reserved for hospitalized symptomatic patients with specific clinical indications, and to be familiar with CT appearance of COVID-19 if accidentally seen on other types of imaging. Societies of Thoracic Radiology and American Society of Emergency Radiology issued a similar joint statement. The ACR position was updated on March 22, acknowledging the need in performing imaging studies to guide patient management in the setting of insufficient testing capabilities, although urging caution in taking this approach. Fresh off the radiology presses on April 7th, the multinational consensus statement from the Fleischner Society was published, led by Dr. Jeff Rubin, and it's added much needed granularity to these broad recommendations, intended to guide clinicians in the use of chest radiograph and CT in the management of COVID-19. A multidisciplinary and multinational panel evaluated the utility of imaging within three main clinical scenarios: varying severity at presentation, community conditions such as prevalence of disease, risk factors for progression, and resource constraints. For example, a scenario depicted provides decision tree for when and how appropriately use imaging when patient presents with mild severity disease in the environment with no significant resource constraints. These guidelines are available online and are discussed in a dedicated RSNA webinar mid-April. Chest radiograph emerges as an important modality to diagnose COVID-19 pneumonia and guide patients' management in emergency departments and inpatient setting. Per ACR recommendation, portable radiography units should be deployed as these machines are easy to clean and without need to bring patients into the rooms. While it is clear that sensitivity and specificity of chest radiograph is inferior to that of CT, it is often the only imaging performed on these patients. While chest radiograph is less sensitive in the early stage of disease, its sensitivity increases with moderate or severe stages. And as we know, in the United States, patients are encouraged to seek medical attention when and if their symptoms progress. Additionally, chest radiograph may guide management in inpatients, providing an alternative diagnosis, such as superinfection, pneumothorax, or pleural effusion. It must be noted that description of chest radiographic abnormalities relatively to the time course of disease is lacking in the current radiological literature, unlike better explored CT manifestations. The table here summarizes most recent publications on the topic, with most commonly described abnormality on the chest radiographs being bilateral, peripheral, and lower zone opacities. A few words about our experience with chest radiographs at Penn. At Penn, we use a portable DR unit in emergency department, utilizing AP projection with either sitting up or supine position patient. A recent paper from University of Washington shared their acquisition technique of chest radiography through the glass of an isolation room door, optimizing protection to a technologist. At Penn Emergency Department, decision to admit versus discharge patient with suspected COVID relies on clinical judgment rather than imaging findings. However, chest radiograph was used to triage patients either to be tested by the internal PCR test developed at Penn, which is faster but had a limited availability, versus sending the sample to an outside commercial lab. It might be going to change soon as the internal testing capabilities increase. Since March 1st at Penn, we had a cumulative number of 655 COVID-19 admissions, with the rate of positivity of PCR in our community in the range of 10–15%. Of all imaged person under investigation, majority, 90%, had chest radiograph only, and the minority had both chest radiograph and chest CT. The peak of hospitalizations is still ahead of us, with a predicted rate of more than 1,000 chest radiographs daily. Cardiothoracic section is very grateful to accept help with interpretation of chest radiographs from multiple divisions across the department. Therefore, we felt a necessity to provide guidance for interpretation for these examinations with a proposed standardized language and structured reporting principles. The benefit of standardized language include uniform reporting terminology regarding the presence or absence of pneumonia and its extent, reducing report variability. We are hopeful that it will provide clear communication with our clinical colleagues and help in decision-making processes. In our next part of the lecture, Dr. Kolansky is going to introduce the proposed standardized language that we have adopted at Penn Medicine.
This is Anna Kolansky, and I will present the proposed standardized language for chest radiographs demonstrate its use with examples, provide chest radiographic CT correlation, and offer some conclusions. We have created a macro termed pneumonia, which can be used in the report impression whenever there is a question of pneumonia in the setting of suspected or confirmed COVID-19, or when there are symptoms listed that can be attributable to pneumonia, such as cough and fever. The macro categorizes the presence or absence of pneumonia and its extent using 4 predefined categories from a pick list. In parentheses, you will also see optional phrases assessing how the findings potentially relate to COVID-19 pneumonia. You will also see in brackets the presence of optional tracking codes assigned to each category, which allow for efficient data mining for research quality control and performance improvement. The 4 categories consist of negative, meaning there is no radiographic evidence of pneumonia, followed by indeterminate, when the radiographic findings are indeterminate for pneumonia and therefore COVID-19 pneumonia or other disease processes may be present. The next category is focal unilateral pneumonia, a finding which is nonspecific and less typical presentation for COVID-19. The final category is multifocal and/or bilateral pneumonia, which is the typical appearance for COVID-19 associated pneumonia. The specific language related to COVID-19 is in parentheses, as usage of this is optional, and the main purpose of the macro is to clearly communicate the interpretation of pneumonia and its extent. The optional tracking codes for data analytics are seen in brackets. The first category is negative. There is no radiographic evidence of pneumonia, and we use this in the setting of clear lungs or when there are chronic changes on the radiograph, such as post-surgical or post-inflammatory scarring that can be confirmed as stable with comparison studies. Let's look at 2 brief examples. This 54-year-old man with HIV and non-ischemic cardiomyopathy was a patient under investigation for COVID-19. His radiograph shows clear lungs and cardiomegaly. The patient was confirmed to have COVID-19 by PCR and required prolonged hospitalization with supplemental oxygen and was discharged at 4 weeks. This is a 59-year-old man with cough and shortness of breath. The chest radiograph shows increased linear markings at the right base. At first, we could say he has an interstitial pneumonia. However, review of multiple prior studies confirms that these findings have long-term stability and represent stable post-inflammatory scarring. The patient tested negative for SARS coronavirus 2 by PCR. The point here is that one needs to make use of comparison studies to correctly identify stable chronic disease, as well as to pick up subtle new findings that could reflect pneumonia. The next category is indeterminate, where the radiographic findings are indeterminate for the presence of pneumonia. These patients may have COVID-19 or other disease processes. This category includes basilar opacities, which could represent pneumonia or atelectasis, chronic lung disease with findings that are not confidently assessed as stable, or radiographic findings with diffuse lung disease where the interpreter is not certain if findings represent pulmonary edema or interstitial pneumonia. Let's see some examples. This is the chest radiograph of a 33-year-old with antisynthetase syndrome with both dermatomyositis and ILD, with new dyspnea and a rash. The chest radiograph shows chronic linear and patchy opacities in the lower lung zones with a questionable new finding when compared to prior studies at the left base, which could represent a pneumonia or atelectasis, noting diminished lung volumes. Given his high-risk profile, a chest CT was obtained which showed multifocal peribronchovascular ground glass opacities unchanged since 2016 and attributable to his chronic lung disease. This patient tested negative for COVID-19 and was hospitalized for a flare of his underlying disease. This next patient is a 66-year-old with HCV cirrhosis presenting with 2 weeks of cough and shortness of breath. His chest radiograph shows bilateral interstitial abnormality, which is new, with asymmetry in the left upper lobe. While suspicious for pneumonia, some may interpret this as pulmonary edema, and there is much reader variability in a radiograph like this one. It was interpreted as indeterminate for pneumonia. Given his high-risk profile, he underwent a CT, which shows bilateral ground glass opacity with interlobular thickening or crazy paving, with extensive involvement in the left upper lobe, but with peripheral distribution in the remainder of the lungs, findings with high confidence features for COVID-19. He was confirmed to have COVID-19 by PCR, required admission to a critical care unit, ventilator assistance, and subsequently had bacterial superinfection with Staph aureus. This is an 80-year-old woman with cough, shortness of breath, and a positive exposure, with new subtle bibasilar opacities. While certainly suspicious, it was unclear to the reader whether this could represent new interstitial lung disease, atelectasis, or pneumonia. She went on to have a chest CT demonstrating peripheral mid and lower lung zone ground glass opacities with high confidence features for COVID-19. She was confirmed to have COVID-19, required hospitalization, and was discharged on day 9 on supplemental oxygen. The next category is focal pneumonia, either seen as a patchy focal opacity or lobar sublobar consolidation. Unilateral disease is nonspecific and could represent bacterial pneumonia, but is certainly seen in early or mild COVID-19 pneumonia. Unilateral disease in chest radiography may also reflect the lower sensitivity of the chest radiograph to detect subtle bilateral pneumonia. This 43-year-old, otherwise healthy woman presented with new myalgias and cough. The chest radiograph shows a unilateral focal pneumonia at the right lung base. She was discharged to self-isolate at home. Her PCR returned as positive, and she had a full recovery by day 16. This 70-year-old man with malaise and fever and a positive exposure had a chest x-ray showing a unilateral left mid-lung opacity, read as focal pneumonia. A second focus in the left upper lobe, marked by the arrow, was obscured by the scapula. A CT done at that time demonstrates multifocal ground glass opacities with interlobular thickening or crazy paving with high confidence features for COVID-19. At that time, he also had small, faint, rounded opacities in the right lower lobe, which were not visible on the chest radiograph. He had COVID-19 confirmed by PCR and had a brief 2-day hospitalization. This 55-year-old man with fever and a cough and multiple chest radiographs demonstrating linear atelectatic scarring at the right lung base has a new focal consolidation in the same lung zone typical of focal pneumonia. He tested negative for the novel coronavirus and was discharged home on antibiotics for presumed community-acquired pneumonia. These are two examples of focal pneumonia where we would not recommend invoking language related to COVID-19, as the appearance does not suggest it. One is a cavitary pneumonia marked by the orange arrow, as seen in this 39-year-old. The example of the right is a 67-year-old with right middle lobe lobar consolidation without any other pulmonary opacity. These two cases are typical of bacterial infection and not of viral pneumonia with COVID-19. The fourth and final category is multifocal and/or bilateral pneumonia, the typical appearance for COVID-19 associated pneumonia, just as has been described by chest CT. This is seen as bilateral, often poorly marginated, faint opacities in the mid and lower lung zones, sometimes rounded. Pneumonia can progress to more dense multifocal consolidation and further to a picture of diffuse lung injury with ARDS. This is a 52-year-old man with confirmed COVID-19 who had a negative chest radiograph on day 2 of illness. He returns on day 6 with increasing shortness of breath. At this time, the CT shows bilateral multifocal ground glass opacities with interlobular lines, typical of organizing pneumonia and typical of COVID-19. The follow-up chest radiograph also shows characteristic bilateral mid and lower lung zone opacities in keeping with multifocal pneumonia. This patient required admission to intensive care unit with ventilator support. This is the patient that I showed you earlier with focal pneumonia on chest x-ray. After a brief hospitalization, he returns with continued shortness of breath. His chest radiograph on day 9 now shows progressive bilateral, multifocal, poorly marginated opacities, some which are rounded and typical of multifocal pneumonia. He was successfully managed as an outpatient on supplemental oxygen. This is a 45-year-old man with asthma, diabetes, hypertension, and obesity with a 1-week history of cough and shortness of breath, a febrile on presentation. He has multifocal pneumonia on his chest radiograph, evidenced by bilateral, lower lung zone faint opacities, some which are rounded in the left lung. The CT shows high confidence features for COVID-19 pneumonia with multifocal ground glass opacities and consolidative rounded densities. His PCR was positive for the virus, and he had a brief hospitalization and a full recovery by day 14. This 38-year-old with chronic thromboembolic pulmonary hypertension and 1-week history of cough, shortness of breath without fever had a chest radiograph with extensive bilateral consolidation, typical of multifocal bilateral pneumonia. The CT scan shows typical findings of bilateral organizing pneumonia, high confidence features for COVID-19. He was confirmed to have COVID-19 by PCR and has required intensive care, ventilator assistance, and has developed superinfection with MRSA. This is a 56-year-old man with kidney pancreas transplant who presents with fever, diarrhea, and without respiratory symptoms. His chest radiograph, however, shows bilateral patchy multifocal opacities with mid to lower lung zone distribution, typical of findings of multifocal pneumonia seen in COVID-19. He was confirmed to have COVID-19 by PCR and was hospitalized requiring supplemental oxygen. This table summarizes the 4 categories and their respective findings, their association to COVID-19, and the suggested reporting language. Both shades of red are radiographs with categories where we can confidently report that a pneumonia is present. These 2 graphs, courtesy of Dr. Tessa Cook from the Penn Center for Practice Transformation, shows the use of our chest X-ray and CT macros across our Penn Medicine system since we instituted them in mid-March, as shown on the bar graphs at the bottom of the screen. We built the macros onto our dictation system and taught the use of them to our residents and colleagues by way of video conferences and slide presentations. Use of these macros continues to increase throughout our system. Both category 3 and 4, focal and multifocal pneumonia, are depicted here together in red. The left graph, demonstrating the chest ray use of the macro, shows that the number of studies where we called pneumonia has generally increased since we implemented the macro and tracks with the increasing rate of COVID cases within our health system. In conclusion, use of chest radiography will likely continue to increase as the COVID-19 pandemic continues. Chest X-ray is often the only imaging test performed in the evaluation of COVID-19 and is used much more frequently than chest CT in the United States. The chest ray aims to identify presence or absence of pneumonia or an alternative diagnosis and is a tool used in decision pathways and patient management. Multifocal bilateral pulmonary opacities are nonspecific but are the most characteristic of COVID-19 pneumonia. Standardized language establishes uniform reporting as to the presence or absence of pneumonia, reduces report variability, facilitates data mining for analytics, and provides clear communication to aid in diagnostic and management decisions. Thank you.